everyone. I'm Dr. C Gupta, Clinical Director and Chief of Vascular Surgery. We have a very unique department here in Care Hospital, which combines vascular and endovascular surgery with interventional radiology, podiatric surgery, and psychology to provide overall holistic and comprehensive treatment to our patients. One of the things that we do very commonly is create vascular access or AV fistula for hemodialysis. It is an ever-increasing problem with increasing diabetes. We are seeing more and more patients going into renal failure and onto hemodialysis. I have with me Dr. Vamsi Krishna, who is a consultant vascular surgeon in our department and is an expert in managing vascular access for hemodialysis. So Dr. Vamsi, when it comes to an AV fistula, we call it the lifeline for a patient because it is because of dialysis that the patient continues to remain alive and do his or her work. How early should a patient go for an AV fistula?
Any patient who is diagnosed as a renal failure, who is in renal failure, the nephrologist assess them, and the planning for the AV fistula should take place at least 6 months to 12 months before he goes on to a dialysis. Because if we don't do that, the patient may land up in emergency and may be needing catheters which are prone for infection.
Yeah, I think somewhere the value a lot of nephrologists talk about is if the serum creatinine is somewhere around 4.5, that is the time the patient should plan for a dialysis. There is a common misconception amongst patients that once a fistula is made, they have to start dialysis. Is that true?
So many patients feel that they need to be on dialysis, but which is not true. We have many patients who are around the creatinine range of 4 to 5 or 4 to 6, and they have made the fistula. We have made the fistula for them, but they have not been on dialysis, and they have been maintained on medical treatment since then. So it's not true that they need to be on dialysis. We can make the fistula for them, and once it is mature, they in case of emergency, if needed, they can go on to dialysis.
Yeah. So I think that is very true. A fistula does not result in dialysis. It is a means created to be used for dialysis whenever dialysis may be required in future. So if you have a creatinine of 4.5, please get a fistula made. It will not put you on dialysis. Dialysis will come as and when it has to come in future. Now, a lot of patients, when they come to the OPD and we are discussing fistula, they talk about grafts, catheters. What are they? I mean, are they equal? Can we offer any one to any patient, or is there a difference?
So, for a dialysis patient, access is a lifeline. So, we need to prioritize what kind of access we need to give to a patient. So, a patient who needs an urgent dialysis, they need to go on, they do have no option but to go on to a temporary catheter or a permanent catheter like a perm cath to start off their dialysis.
So these are patients who would not have had a fistula made when the creatinine was lower and have waited till they need dialysis.
Dialysis. So for a patient who is not on dialysis and has time, we prefer to have a native vein to create a fistula, which always helps. It is helpful. Some patients do not have any veins in their upper limbs. So in those patients, they need to have a graft, which is an artificial PTFE pipe which we use to create a AV fistula.
So if I were to ask you, in terms of prioritizing where you would make the first fistula, where you would make the second fistula, would you have a third option in the upper limb?
Yes. So whenever a patient comes, we need to screen the patient with an ultrasound to see for the proper vein. So choosing the proper vein and the proper artery will give a benefit of increasing the survival of the in proper maturation of the fistula and also long-term outcomes of the fistula. So our preference would be to start off with a non-dominant limb and that too as low as possible in the forearm. Then if forearm is not available, then we go on to the arm. Arm veins are also not available, then the final option would be to use a basilic vein, which we uh, transpose to create a fistula.
Okay. So, are there certain patient factors, for example, diabetes, age, vascular disease, having had previous punctures in the veins, do they make a difference in how the fistula may be created or how it would function in the long run?
Definitely, patient factors play a major role in deciding how the fistula functions, and also the place where we create a fistula, especially in very old age people, or people who have very calcified arteries. We would prefer to go higher into the arm to create a fistula, so that they have a proper fistula and early maturation of the fistula.
So, once a fistula is made, what precautions or care does the patient need to take so that the fistula develops well? We call it maturation, which means that the fistula is now ready for use. So typically, how long would it take a fistula to mature, and what can the patient do to facilitate that?
So typically a successful fistula would take at least 6 weeks for the vein to mature. Maturation would mean that the vein is about 6 millimeters in diameter, so that they can cannulate the vein. So once the fistula is made, we need to make sure that the limb is kept clean. It should be cleaned properly every day. Then we make sure that the wound is healed completely. And once the wound healing is complete, we need to make sure that the patient feels the thrill every day, so that we can monitor the fistula. For a forearm fistula, it is always advisable to do exercises with a soft ball, which helps in maturation of the fistula.
So, what are the things a patient can do to make sure that the fistula works for a long time?
For a mature fistula, the patient needs to make sure that he feels the thrill every day, so that he knows how the fistula is working. Any change in the thrill, that either it is the thrill is or the sound is increasing or the sound is decreasing, he should make sure that he visits the clinician to see the problem. Once the patient is on dialysis, if there is an increased bleeding or the dialysis is improper, he needs to see immediately. So identifying these small problems will help in making sure that the fistula is functioning. Also make sure that the skin where the punctures are made are healthy. Make sure that there is no redness or blood which is extravasating, and keep the area clean.
So, what I get is that surveillance is important. So, it starts with self-surveillance or self-care by the patient in feeling the thrill on a regular basis, maintaining proper hygiene, seeing that there are no ulcerations or redness which might indicate infection. Then surveillance by the dialysis technicians, ease of puncture, any clotting, any excessive bleeding, the quality of flow, is it low flow is decreasing. And then I think another important thing is surveillance by your vascular surgeon. So you need to periodically visit your vascular surgeon, who can examine the fistula, check the entire fistula with ultrasound, and detect any problem that might be creeping up, which can result in malfunction or failure of the fistula. So, Dr. Vamsi, if there is one thing that you would like to tell patients on dialysis with an AV fistula, what would you like to tell them?
AV access, the vascular access is their lifeline, and I think they should maintain they should take proper care in maintaining the vascular access, and should listen to proper advice when maintaining the fistula.
Yeah, so I think just at the end, I'll go back to the beginning, is how do we plan for a fistula? In today's date, having an ultrasound assessment of the veins, I think should be the standard of care. Gone are the days where the surgeon would make an incision and then say, oh, I didn't find a good vein, the artery is not good, and close the incision. In today's date, the vein and artery should have been identified well by ultrasound, and that is when the fistula should be planned and made. And for patients, if you take good care of your fistula, have regular surveillance, I think the fistula can last long and dialysis can continue for much longer than it used to earlier and help you maintain a good quality of life. Thank you, Dr. Vamsi.
Thank you.